you can go on the next slide. So we will, with this meeting, what we plan to do here is just a little bit introduce this new supportive content that we have sent to you. And here I will need you to confirm if you have received this content and if you have it on your computer, if you have access to it. You should have received it because this is how you signed up for this meeting. But just please confirm, Carmen and Joanna, if you have seen the material that we will be introducing here today, because this depends on afterwards how I will introduce it, or how we will introduce it. Carmen, have you seen the material, the marketing material? Joanna? Joanna hasn't yet. Okay, no problem. Carmen?
Oh, there is something in chat.
Okay, that's just because Joanna, for your information, so we have now created a completely new, brand new. Can you hear me? No, unfortunately, I could not, Carmen. So we have created this new. I can see your slide. Okay, thank you. So we've created a brand new material to help a little bit promote this special product. And the idea of these meetings is to discuss together how we can and learn from each other how we can use it. So that's the primary goal of this meeting. If you haven't seen the material yet, this meeting is now just going to be about introducing it a little bit to you, okay? And you will come back to us with any questions. So the idea is to use this material in clinical practice. So when you visit your surgeons, which material you can use in, which clinical situation. So that's the idea to, introduce this a little bit today. And obviously it will be very important. Today we are among us, so which would be very important to have your feedback and your experience and, country specific information. That would be the idea. If we have sound issues, it's going to be a little bit difficult, but please feel free to write anything, because we want to hear from you. Again, this is not a lecture. This is a discussion type of meeting now. Yes, that you can jump the slide. Okay, the next one. So just a little bit about the introduction here. You know this product, so I don't have to go through the technical details. But when you speak about the product, when you actually want to kind of hand over a knowledge to your surgeon or introduce it to your surgeon, it always starts by the physical properties, the features of this product, why it was designed the way it was designed, and why this is exactly the shape that we believe is a sulcus fit shape that has also been patented, the design, and why this is, we believe, the best platform on the market for a sulcus-based optical enhancement. So you know the four haptic design, you know that it's a non-torque design. Very importantly, it fits to different sulcus sizes and shapes, as well, the square design to avoid iris capture. So this is just a reminder. We always start by the physical features of this product. And if you go to the next slide, you also know why, when, as we designed it here to show you its place in the sulcus, the sulcus is a very special place. You have to really adapt to the circumstances there. And this is why these physical properties of this lens with the polished edges and the convex concave platform were designed to have a long-term stable positioning in the ciliary sulcus. That's, absolutely, this is when you go into the OR or when you go into discussion with the surgeon, this is always the start of the discussion, that you should be aware of the physical features of this product. And if you go on, we will also just briefly tell you, one of the primary aspects that you will speak to your surgeons about this product is, why lens-based enhancement? Why not just do LASIK or PRK touch-up? Why is it any better? And already in this very first argument, the main advantage or the main feature of this product is going to come to the forefront, which is that it's reversible. Anything you do on the cornea is irreversible. Anything you do with the add-on is reversible. Why? Because you can remove it from the eye anytime after the surgery as you please. So it's a reversible procedure. This is always, just remember, number one advantage. whatever we speak about, enhancement, trifocal upgrade, whatever it is, it's all about when surgeons consider this product, it's all about the reversibility. And this is, if you go on that with the this is the portfolio we have, you know it, but of course you always have a data sheet in your hands when you visit your surgeon, so you can always give the information they need, you know, about the range and about the steps, and also about the precision. Again, we have especially in the toric range 0.25 steps on the cylinder diopter steps, so not 0.5 but 0.25 diopter steps, which translate, this is on the sulcus plane. On the corneal plane, this translates to 0.14, 15, depending on the eye, diopters. So this is really a laser precision, as we like to say, because of that 0.1 precision on the corneal level. So that's a very important aspect, that this is a high precision optical enhancement device. And now, if we just, this is just to summarize the features. Okay, this is, of course, you will have this presentation, so you can always remind yourself which lens of the portfolio provides which feature. Okay, but the important part is coming next, which is to use the new material, because this is from the trifocal surgeon brochure that you received. And we will go through this new brochure today. But here I just want to highlight, if you go to, or let's go now together, because I think you don't have it in front of you. If you go to the pages 4 or 5, this is immediately the 4 features of this product. Joanna, you know the surgeon on with the testimonial on the photo. So you have these 4 features which are explained you know, in a very easy to understand and detailed way, you know, why we have this 4 features, and how, more importantly, how they act, or how they perform in the sulcus on the long term. So this is, we will not go through all these features now, but this is just to remind you, you open up and you can immediately, of course, explain to your surgeons these 4 functions that I explained to you before. Okay, so this is just for a start. And when we go, this is nothing to be complicated here, but when we, what we advise, and this is how we worked out, this is just kind of line of thought, that how we think it's an effective promotion. Each country is different. Maybe you will tell us that you have other ideas, and we are open to hear it. But what we want to do here is to give you a kind of, you know, an idea about what steps the promotion could go through. Because obviously you have most of your surgeons that never use this product. 99% of your surgeons in your countries never use this product. So you should approach them, and you cannot approach them with, you know, 15 different ideas of indications and usage. So it's much easier to have a clear, logical path, and it all starts with pseudophakic astigmatism correction. It has been the primary call in our experience, with over 10,000 lenses implanted already around the globe in the past 10 years from this product. Astigmatism correction has been the primary call to have patients come back and undergo another surgery after cataract, after removing their cataracts. And this is to correct their residual astigmatism. There can be many reasons for that there was no toric lens available, or the surgeon is not comfortable with toric lenses for cataract for whatever reason, or the surgery didn't go as planned. For whatever reason, we see that a lot of patients after cataract have a residual astigmatism. So usually with this product, we find surgeons that want to correct that, okay? And if you go on, if you have this idea, or can advise this idea, that if you go to the next part, what is very important, that immediately you always start with the scientific evidence. So this is the most important. You always point out, you know, when you find the right indication or the idea of usage, so you have this interest in the surgeon's mind, you always start by the scientific evidence that we will introduce to you here today, because we have also created content to help you explain the scientific evidence. Very important. This is the #1 pillar of your efforts. And then if you continue, we like to, these are the materials that we will show you within the scientific evidence, okay? And if you go on, we advise that after going through the scientific evidence, after showing the safety and efficacy aspect of this product, you then have the chance to include more ideas as a kind of a top-up function. For example, that we will explain to you the trifocal upgrade. So let's say the patient comes in for a astigmatism correction, but you have the option not only to correct distance vision with the astigmatism correction, but also to give near and intermediate vision with the trifocal toric add-on. And so these are the ideas, or this is the line of thought that we would like to go through with you, because this is what's most effective in our experience. Yes, that you can go on. And there is also a parallel side to this, because a lot of surgeons now, especially in Germany, but also in Australia and other parts of the world, have a prospective idea. So they don't only use this product when there is a problem after cataract surgery, but they plan with this product already to correct trifocality in a reversible way, meaning they already plan with 2 IOLs, 2 lenses already for patients undergoing cataract. This is a completely different idea, which is also very successful in a few countries already, okay? But this is a different line of thought. This is a different promotion, and therefore also requires different communication. However, the scientific evidence aspect, so the safety aspect, is exactly the same. So you have to understand it doesn't matter if it's implanted in 2 steps or in 1 step. The scientific evidence in the sulcus that we have available applies to all situations. This is just to show you and I find this very important, why we think it's the astigmatism correction that is so relevant with this product. It is because you see here the amount or the share of patients with uncorrected astigmatism. This is a study from the UK with almost 40,000 patients. So this is a cohort study, a retrospective study. And it shows you that basically still almost 20% of patients, and it's the UK, so a very developed country. So every 5th patient has an astigmatism of at least 2 diopters, which means that, or 2 cylinders, sorry, which means that every 5th patient is a potential customer for the first Q add-on, because with a 2-cylinder astigmatism, you will obviously not have a good quality of life, and even glasses correction can be bothersome to a lot of those patients. So this is a huge market. This is why we speak about it. So this is the first poll. If you just go to the poll, Detti, please.
It's not coming. We still have some. Wait, yeah, we still have some slides until that. But if you want,
but I want to.
I can include the poll now. I will start it.
Because we finished this section of and here we just ask you to choose one option. We have some questions to you. Can you see it? Okay, so just please answer these questions, okay? And we will discuss them afterwards. And before we go on, I think it's more logical to do it now.
Okay, so here in the first section, we will have 3 questions, and I would like you to scroll down and answer each question if you can. So the first question is, this is a multiple choice question, so it might be that there are more correct answers. What are your typically used ways to correct residual astigmatism at this moment? Pseudophakic refractive surgery, spectacles or contact lenses, IOL exchange, or secondary IOL or add-on implantation. The next question will be, when considering the trifocal add-on, what type of refractive errors can you correct? This is also a multiple choice question. Myopia, hyperopia, presbyopia, and astigmatism. And the third question is, just if you know, and we will talk about it later, in patients with keratoconus, which is the first, the correct answer? The first Q add-on IOLs can be considered even in ongoing corneal tissue changes. The second option, the add-on IOL power calculation can be only based on subjective refraction. The third option, trifocal add-on can be considered in case of keratoconus patients, or the pseudophakic ACD measurement is reliable for the calculation. So I would like to ask you to answer these questions. I can see how many of you have already participated. And now if you give me the answers, then after that, I will end the poll and show you the results. It's also important for us to know what you know about these things, if the messages go through, or if not, then we will talk about these issues in details.
Exactly. So the only reason here is just to understand if we should go into the details about any of those, or we can move on.
I haven't received any replies yet, so I would like to encourage you to send your votes.
Yes, Carmen and Joanna, please sign in or vote.
Does it work for you? Because nothing happens. Can you see the questions, please?
I can.
You can, okay.
Jean-Baptiste, please also vote. Maybe there is a problem.
Maybe there's a problem which we have. Okay, I will check the chat. Not vote directly. Oh, you cannot vote. Okay, you can't see the questions. Okay, then, Freddie, I would like to, probably we have to work on something, probably some wrong adjustments. Then I would like, if you can talk, or if you have some sound issues, it doesn't matter, just write in the chat. So what do you think? And then we will talk about it in details. So could you please then write in the chat that what are your typically used ways to correct residual astigmatism? Pseudophakic refractive surgery, spectacles or contact lenses, IOL exchange, or secondary IOL and AddOn implantation. How do your surgeons correct these residual astigmatisms? Freddie, can you please check the chat for the answers?
Yes. I don't see any yet. Can see the questions. Maybe they are coming. The problem of Joanne is that she cannot see the questions. Okay, Joanne is writing. She doesn't know the answer to these questions, so we will just go through them. No problem. This is just a here. Okay, so what are typically used ways to correct residual astigmatism? So obviously, sorry, one more message. Spectacles or contact lenses? Yes. So actually, and it's a good answer, Carmen. So here, what you can see is that, you know, after cataract surgery, you have in some situations refractive errors. You know this situation, and what happens is that the surgeons have many chances to correct that problem. I mean, historically, or the most common, as Carmen says, is spectacles or contact lenses. However, you have many patients, Carmen, that I'm sure you also in your country that do not want to wear spectacles or contact lenses. Let's say, but because in their life they never wore contact lenses before, so they just say to the surgeon, well, I don't want to wear it. Find a solution for that. So in the end, the surgeon can opt for all of these options. About pseudophakic refractive surgery, so LASIK or PRK after cataract, a lot of them are done. Of course, IOL exchange, so you can do another cataract types of surgery, or not cataract surgery, but you remove the lens from the capsular bag and you put in another one with a different diopter, so it corrects the distance vision. But this is very traumatic, much more traumatic than all the other options up there. This is a big surgery then. Or you can do a secondary IOL implantation without actually touching or bothering the lens in the bag. So you can just place another lens on top of it, which, as you know, is reversible. This is the big advantage of it. Okay, so all these questions are correct. And this is important that we speak about it then. That to the second.
Yeah, the second question was, when considering the trifocal add-on, what type of refractive errors can you correct? And you could choose myopia, hyperopia, presbyopia, and astigmatism. And luckily, you can correct all of these refractive errors So the add-ons are suitable for myopic patients, hyperopic patients, also for those who have presbyopia, because with a trifocal add-on, you can correct presbyopia as well and give a functional intermediate and near vision on the top of good distance vision. And as the trifocal add-on has a toric model, a toric version, you can also correct astigmatism. So the trifocal add-on is suitable to correct all these refractive errors. And the third question was, it's a bit more difficult and more tricky one. It was about the patients with keratoconus. And
everybody, sorry, because Carmen and Joanna, keratoconus, are you aware with the concept of keratoconus? What it is? As a corneal situation? No, okay, no problem. So this is a more specific cornea problem. So this is a corneal bulging, a thinning of the cornea, and you know, a very high, usually myopic and astigmatic error happening because of that. Okay, so you have a lot of those situations in well, quite a few of those situations, especially in when the patients are in their 20s and 30s. Okay, and it can be corrected in many ways, but typically what happens is that the patient will be left with some high refractive error. And these high refractive errors, even after cataract surgery, sometimes are staying there because it's very difficult to calculate the good lens for that, okay? The good lens power for that. So this is just an example that you can use the the toric and the refractive add-ons to correct even larger amounts of astigmatism. So even more difficult cases can be solved with the help of this product. In fact, many of your surgeons, when you start selling this product, will actually look for those more difficult cases, and then they will convert to the more easy cases because they like to see how it solves those cases. Okay, so we can, I think, is this clear? Can you show the answers maybe, Detti?
Can't you see that? I mean, I cannot show you poll results because our attendees couldn't vote, but all in all, the possible answers were for keratoconus patients, which was correct. The first Q add-on iOS can be considered even in ongoing corneal tissue changes. This is false. Freddie, can you explain it to them?
Yes, so in general, we don't have to focus on this specific example. In general, the add-on cannot be used in any type of pathology that is active, meaning if you have an ongoing situation either in the cornea, but the same goes for the retina, because many times you have a retinal detachment and after that you have a big refractive error as a result. So even in those cases, the add-on is sometimes used. What you should only remember, forget about the test in this case, or the question, the poll. What you should remember, in all of those cases, you cannot use the product unless the pathology of the eye, so the eye problems are treated and are stable. So there is no changing process that may change the refraction of the eye as well as a result. Okay, this is just what you should remember. This is a more specific question. We just wanted to see, you know, these cases as well. Okay, so that T from here, I give it all. Sorry, before that, let's just go now, please, to the OR setup, which we created as a supporting material. Exactly. So my question here, this is, I think, what is a little bit more useful here to you today. Okay, you have here an ophthalmology practice with the typical rooms. Of course, each of them is different, but you have typical rooms and opportunities for discussions in the OR. My question, Carmen and Joanna, are you visiting ORs on a regular basis or ophthalmology practices on a regular basis in your everyday work? Joanne is office-based, okay, and Carmen? Everybody's office-based, okay, so it doesn't matter. So in this case, it's just, you know, good to understand in general, you know, that the new material that we have created is you can kind of group them or use them in different situations. So you have obviously when you go inside the consultation rooms, or you can say waiting rooms, where you can already place out some material primarily for patients, or the waiting room videos, for example, which we also have now, a patient video. Obviously, when you go in the doctor's room, so where the surgeons are, you know, conferring or discussing with each other the different solution to different cases of that day, they can discuss among themselves, you know, about the special product like the add-on. So here, the materials that we have created are typically a very good support or a very good aid in that situation. And of course, you also have the operating room, which is, of course, the most important place in this setting. And we have a lot of application materials. So how to use the lens in a clinical practice. We have, of course, a guide how to load the lens and how to implant the lens, very importantly. Then you have the visual acuity testing room, obviously. And connected to that, or usually almost in many cases is the same examination room, is where the calculation starts, because you start the process of the add-on order basically by, of course, determining the right power of this lens, which starts by measuring visual acuity and doing the examinations of the eye. And we also have a supportive guide for that, for the calculator, okay, what you need for the calculator and how you need to use it, okay. And of course, you have what is very important for all these situations. All of you should be aware of the instructions for use of this product. So never forget about it, you know, with all the indications, contraindications, and so on. So, you know, all these materials are essential, and you should be able, or if you are not visiting the OR, then your colleagues should be, of course, able to place them and use them in the right situations and hand them over to the right person. Okay, so this is just an explanation. And with this, as you understood from the chart before, we will move on a little bit to the scientific evidence side. Okay.
Okay, then I will go on if you don't mind, Freddie.
Yes.
So when you will first try to convince doctors, we would like to suggest you to find a devoted surgeon who is already well experienced with cataract surgery and the implantation of intraocular lenses. So we need an experienced cataract and refractive surgeon first, who is precise and demanding for his work with good surgical skills, and who is willing to perform lens-based correction versus the conventional laser corneal refractive surgeries. So he should have an open mind for these new solutions. And it's very important for him to set realistic expectations for the patient and explain the patient what can be expected, what not. For this, he has to understand that he will have to devote a chair time, a specific chair time for these, and communicate properly with the patient. But all in all, these materials are for you and for him to have this communication and to reduce this additional chair time as much as possible. So as for the absolute and relative contraindications for the add-on lenses, we think that the primary source of information should always be the instructions for use document, which you can find on the FirstQ website in different languages. So when we would talk about contraindications and indications, we always say only our suggestions or translate our KOL's opinion, but we do not say that it's forbidden or it's a must or something like this. But the final decision if implanting the lens or not should always come from the doctor, and it's always the surgeon's responsibility. So there are some off-label uses for also other lenses and not only sulcus lenses. Off-label use which is not in the product IFU. These might be successful, but in the case of an off-label use, either Medicontur or FirstQ shouldn't be responsible for the clinical outcomes and the possible adverse events. So we say what we know about the clinical practice and the experiences that we have so far. We let the doctor know how it goes, but the final decision should always come from him. Okay, and now if we go forward, first I will introduce you this indications info sheet, which is a 2-pager document, and it aims to introduce the basic and special applications of the add-on lenses. Each of these applications, which we highlighted here, are clinically proven. There are many more applications as well, but until we have clinical proof for it, that it's safe and efficient, we won't include it into these materials. So this is for getting the idea in different clinical situations, and then the doctor should realize that, oh, I have a patient like this, probably then the add-on would be a good solution for him. So on the first page, you will see the basic applications like refractive correction, astigmatism correction, trifocal upgrade after cataract surgery. And also we mentioned this planned dual procedure that Freddie already mentioned, and we will talk about in details later on. And if you turn the page, on the back side of this document, you can see the special applications, because in some difficult, challenging situations, the add-ons can be the jail out cards for the doctor. And for example, if the doctor has a post-keratoplasty patient, there might be some residual refraction, which you couldn't predict how big it will be, but with the add-on, you can correct this as well. And after PPV, pars plana vitrectomy, sometimes there is a refractive shift in the patient, and until this is solved by itself, then you can use the add-on as a temporary optical compensation, because in this case, there can be approximately 5 to 6 diopter difference between the two eyes, which is quite much for the brain to deal with, to compensate. So
Definitely, I'm sorry to interrupt. Just, I think it's good to answer the questions if they arrive. No.
Yes, if you have, can you see them?
Yes, is this info sheet also available on the website? So what is very important is, and we will then communicate this a little bit more clearly. So these materials that we introduced to you here today were just launched, and we've sent you a newsletter with all the material in a downloadable format. So if you open it, I don't know if you all received this. As I understand from Joanne, she did not receive this. So right now, these are available or downloadable from this communication, this newsletter. They are not yet available on the website. In fact, there is a new website being prepared, and it will be available on that. But for now, we have this material for you downloadable in the newsletter, or we can just send it to you, okay? So everything you see here, you already normally you already received, okay? Some of you, it seems you have not. No problem. We will, after this meeting, we will send you again each of these materials so you can have a deeper look in them, okay? So this is very important. Thank you for the question, John.
Okay, now if we can move on to the next document.
Sorry,
so yes. So this was only just a teaser, just to start the conversation and show the opportunities that lie within this product group. Okay, if we go on with the science brief, we already mentioned this, that everything that you can read or what we talk about is clinically proven, and we have clinical studies and clinical experiences behind it. This is a 4-pager document, and we find it really important because some of the clinical and scientific articles are not open access, and the doctor won't be able to read the whole text. And on the other hand, sometimes it would take so much time to read all this information that now we have made a short 4-pager summary of all the knowledge that we currently have about the add-ons. And this is an ease for the doctor because he doesn't have to read so much. It's a quick overview, but we can also help them to interpret the scientific results. So this is mainly for the doctors who can be convinced by clinical evidence, and hopefully the link will work, because if I click on it, there should be a flip book opening. Just a minute. Yeah, it's opening here. So we will be able to, you will be able to turn the pages. So if you look at this, on the top of the page, you will see a main message, just like here, safe in the sulcus. the next page, effective refractive correction. And under these main messages, you will see some more smaller but very much important messages regarding this safety topic, for example. This structure stands for all the other pages as well. And if the doctor is not so keen on reading, he can just simply look at the graphs, which are from scientific articles or which summarize the clinical evidence that we have. So this is a quick overlook just to show them that it really works and what the clinical experiences say to us. And on the fourth page, if we go on, again, this is a third very important message that the stability in the long term is also proven with very interesting messages down there. And on the bottom of the page, you can see the references that we used, either scientific articles or Congress presentations. So if somebody is more interested in the details, they can search for these articles and presentations, and they can have the details. So now I would like to go back to the presentation. Hope you can see that. So this is the science brief, mainly for doctors who can be convinced by clinical evidence. And you have probably met this document, this so-called add-on supplementary issue of the Eurotimes magazine. This was released in 2021, so this year in February. This was a supplementary issues, and it summarizes in 4 pages. It summarizes a lot of things that we already know about the add-ons. You can read about versatility, reversibility, and the physical stability, which is a base for having an efficient toric model. You can read about the clinical outcomes and also the future prospects that lie within this product range. And several well-known experts, surgeons from all around the world contributed to making this supplement. So this is a really quick overview, and we hope that your doctors or even you can use it in your clinical practice. And hopefully I can open this document too, just for you to see how it looks like. Yeah. If we turn the page, you can see all the details about the 4 features, about the doctor's experiences. They will share you how they use the lenses, what they use these lenses for, and what are their experiences so far. Right. Then if we go on, we can have a second poll. I don't know, Freddie, if we want to make the poll now that we have difficulties.
Just show the questions, please, and we will briefly discuss them, okay? We will not go in detail. Unfortunately, the polling seems to be, even for me, I'm not able to click on the answers for whatever reason.
I think we made an adjustment mistake, but I suspect what the problem is. So next time we will be.
But either way, it's not an issue. It's just we will discuss, because this is actually quite important. So I've talked about this in the introduction part when I spoke about why the toric add-on is usually the call for surgeons to try this platform. And if you could just have a look at the first question here, I assume you can read it. Carmen, you can read it for sure. I hope, Joanna, you see this as well, but I will read it as well. What percentage of pseudophakic patients have clinically significant astigmatism of at least one cylinder after cataract surgery? What do you think? If you could write in the chat, because I spoke about this, that would be excellent, because this is so important when we speak about this product, this argument. Do you remember this?
So we are talking about pseudophakic patients who have already undergone cataract refractive surgery. This is very much important, because they are the most important pool for us that we can work with, the most important market potential.
Could you write in the chat, some of you, what's your guess? Okay, yeah. Carmen was was listening, but maybe Joanne, if you can see also. If you remember, I said 20%. It was tricky because I said the 20% for 2 cylinders. So at least 2 cylinders have 20%. So in this case, it will be higher because the question has who has at least 1 diopter cylinder. So this is significantly higher. This is why it's so interesting. That to reveal the result, please. Oh, maybe you
Yeah,
can.
the correct answer is 60%. This is huge. So if even
Exactly.
one, yeah, even one
Carmen was
diopter,
writing.
yes, even one diopter untreated astigmatism can cause decreased vision at all distances, so not also in distance vision. So, and especially if you want to implant a trifocal lens or a multifocal lens, then the correction of astigmatism is even much more important. So we have several other courses regarding multifocal lenses and astigmatism, but now you just have to know that, especially when we talk about multifocal lenses, the correction of astigmatism is of utmost importance. And now if the patients, the 60% of patients has not corrected or suboptimally corrected astigmatism, this is a huge number, and they are all potential customers for these lenses.
And the second question is what I discussed or what I introduced. Okay, so who has at least, because when you speak about obviously a surgery, you want the error to be high enough to undergo, you know, another surgery, right? So when we speak about this kind of you know, threshold of vision, when, you know, the quality of vision is already quite bad, you know, and then you consider undergoing another surgery to correct with another lens, with the AddOn, first Q AddOn lens, right? And we believe it's about, you know, 2.5, two cylinders are already, you know, sufficient to consider this. And this is why the second question I answered, and it was correct also. Carmen answered this. Okay, so this is about 16, but yeah, 16 to 20% are absolutely considered to have this amount of residual astigmatism after cataract surgery. So just keep this in mind, please. Okay, and spread the message, because this is our primary call to sell these lenses. Okay, we can go back now to the next one.
Yeah, so we will go on now.
There is, yes.
So now when we already know how to call the patient in and that we can offer them astigmatism correction, it's not a must, of course, because they can come in for other reasons as well. But now that we know this, what more can we offer? What's the next step? In this step, you already talked to the surgeon about the clinical safety and the efficacy of these lenses. And now the surgeon hopefully associates to the phakic astigmatism corrections with the first Q AddOn. So what's next? What more can we offer? And this can be the trifocal upgrade. So if the patient was implanted with a monofocal lens, which was aimed to correct their distance vision, now you can offer that, okay, now I correct your astigmatism, but what if I will give you a good intermediate and near vision? And if everything goes well, you can probably get rid of your spectacles forever. So for this, we prepared a surgeon brochure about the trifocal add-ons and the option that they have. I will open it as well, and we can go page by page. This
yes,
will
so
be
here, sorry,
yeah.
that just to you know, this brochure is our strongest printed material, so to speak. So it has really, the idea to develop this brochure was, you know, have everything at once with testimonials. So as you will see, and the way you should use it is, you know, find those points, find those testimonials that relate to your doctor, that relate to your surgeon who is considering to use the product, and use those arguments. So look for those parts in this brochure that is directly usable for you. Okay, very important. This is the strongest material that we have here, and we should go through this. And now is the time to pay attention, because you have this material, and please use them effectively. So if Datti will open it, yes, Datti, sorry.
Yes, I opened it. So on the first page, you can see some short introduction, and all along the whole brochure, you will see some testimonials from doctors that are regular users of our lenses. And on the right page, you can see these three calling words: this upgrade, improve, and plan. So upgrade of pseudophakic patients means, as I mentioned, that for their monofocal lens, you will give some additions, some trifocality, so that they can get rid of their spectacles. Improve visual outcomes is also, of course, if you give an improvement, if you give trifocality, you can either improve their vision, and if the patient had any residual refractive errors after the cataract surgery or astigmatism, you can also correct these with the trifocal add-on lenses. And the third option, this much different option, is the planned dual implantation, which means that there is a dual lens system of a monofocal IOL in the bag and a trifocal trifocal add-on in the capsular bag. And this can be achieved with one simultaneous surgical intervention or sequential surgeries. The highlight is, and the emphasis is, that it's planned. So it's not like you had a patient implanted with a monofocal lens, I don't know, years before, and now he comes back. No, it's planned, and we know that we will implant 2 lenses in 1 or 2 steps. So this is a planned dual procedure, and there is a need for it in some circumstances. This page we already showed you. These 2 pages introduce the 4 main important features of the lenses, which are crucial to maintain safety and stability in the ciliary sulcus, because the sulcus is a special implantation site. But when designing this lens, the designers and we have thought about many things that can come up after implanting into the ciliary sulcus, and we try to create this lens so that it will fit the sulcus as best as it can. If we turn one more page, then you will learn about the trifocal optics of the lens, the so-called EPS technology that Medicontur also uses in the Liberty lenses. For the Liberty as well, we have much clinical evidence. So here you can see about light distribution and light scattering, low light scattering, and why the optic looks like as it does. And on the right side, you will find the clinical evidence from Spain. We have a really good expert there, Professor Carlos Palomino Bautista, and he made a study with a monofocal capsular bag IOL plus the add-on trifocal in the sulcus, and he has really nice results, and his patients are very much satisfied with the clinical outcomes. And if you look at this graph up here, this defocus curve, you can see that the visual performance of this monofocal IOL plus add-on trifocal combo is at least as good as a trifocal capsular bag IOL. Namely, this is a fine vision lens, which was the golden standard, the first real trifocal lens on the market. So here again, you can find the clinical evidences. And on the back side of this 8-pager, you can see the technical sheet of the lenses, the diopter range, so that the doctor can directly plan what if he wants to use these lenses. And again, you can find the references. So if he needs some further reading, he will find these sources online. Okay, so I just go back one more time.
And let's have a little bit of a feedback here. Is this understandable? Do you see why it's built up the way it is, the logical sequence? What is, Carmen and Joanna, I ask you primarily, what is your feedback here, or is anything that maybe needs further explanation? Because this is one of the unique opportunities for you to ask about it. What do you think? It's more or less clear. Just waiting for the message on the Skype. I think it looks very well laid out. Okay, Joanne, thanks for the compliment. Okay. Okay, so thanks, Joanna. So it seems that there is no specific question. It was understandable. Yes, it is well laid out. It's nicely sequenced with all these arguments. I think this is a primary weapon here for us to build up this logic that we explained here today. Okay, we can, however, continue still, because of course there are several other documents.
Okay, then I will launch.
Technical explanation combined with clinical evidences, Carmen. Yes, this was the primary aim to not make it too technical. So we always put a testimonial, kind of a personal aspect, next to each. So this was the primary goal. But since this product is a special product, it's, a lot of surgeons, have a lot of questions regarding safety and efficacy. This is why we have to very efficiently explain, why they can rely on this technology. So this was the idea behind this material. Thanks, Carmen. So here is the fourth poll or question. I think I should read again. This is a very simple question, but it just so you the kind of a take-home message. If this was clear what we explained so far. So, which patient of the following is a candidate for trifocal add-on implantation? Okay, so this is a question for you. If you can write in the chat. Once again, sorry for the technical difficulty here. All of you, if you could write it in the chat, which one do you think which patient is a good candidate, is a candidate for trifocal add-on implantation? So number one, phakic patient, aphakic patient, pseudophakic patient with monofocal toric capsular bag IOL, pseudophakic patient with trifocal capsular bag IOL. Which one do you, okay. Carmen was writing third answer. Maybe Joanne, do you have a guess? Or if not, we reveal. Thanks, Carmen. So it's absolutely correct, huh?
Yeah.
No problem. Yeah, third. Joanne also answered the third. Excellent. This makes us feel good because this is important that you understand this concept. Absolutely correct. Thank you, guys.
Okay, then we will move on. So the question is there a market for the first Q add-on outside of the group of patients who already undergone cataract surgery or refractive lens exchange? And of course, this we already talked about, that the add-on can be used as part of a prospectively planned intervention based on the implantation of 2 IOLs. And this will lead us to the next document, which I will open soon. This is the so-called planned dual implantation. And here you can see some text taken from this brochure just for the doctor and also for you to understand this whole concept that lies within. So it's mainly for presbyopic patients who are somehow either not suitable for trifocal capsular bag IOL, or there are other difficulties which make it questionable if a trifocal capsular bag IOL is a good decision. So in this case, we suggest to implant a monofocal capsular bag IOL, just a simple monofocal one or a monofocal toric when needed. And plus, you can implant a trifocal ciliary sulcus IOL, an add-on IOL. And you can either do it in one session or in 2 different sessions, but in a planned way. So in the end, the patient will have a trifocal vision, which is identical to that he could have received with a trifocal capsular bag IOL. But in the case something happens, or if he's not satisfied with the visual outcomes, you can always take the trifocal add-on out, and then the patient will still benefit from the corrected distance vision and astigmatism correction. So all is lost would be only trifocality, but the patient will still have a good vision for distance. But as for our Australian expert, Dr. Harrisburg from Sydney told us, he never had to explant any add-ons. So the patients are highly satisfied and he had no problems, so that he should have implanted the lens at all.
Is this concept clear, Joanna and Carmen? This concept of using 2 lenses already for patients before or undergoing cataract or refractive lenses. Thank you, Joanna. Okay, so it's clear. It's a little bit for some of our partners. This is a very strange idea. It was also for us, a couple of years ago when surgeons came up with the idea of using 2 lenses, but it's a strong argument because the reversibility aspect is very important when it comes to trifocality or diffractive optics. As you know, not everybody is going to be happy with the even if the low amount of this photopsias with any diffractive optic. And for those, especially in some professions, engineers or truck drivers, all those people who, you know, where you think that, you know, a diffractive optic is maybe not the best idea regarding the profession. However, the patient is adamant and they really want this technology. They are willing to pay for it and they push the surgeon. You know, in these situations, among others, you might want to think, let's make it reversible. Let's give this additional option. And if there is anything down the road in 5 years, 10 years, or unsatisfaction due to the diffractive optics, you just remove the lens without touching or interfering with the distance vision at all. Because when you remove this lens from the sulcus, you simply remove the diffractive lens, but you still have in the bag the correction for the distance, the full correction, including toric and spheric correction for the distance. So this idea is very strong and it starts to work. It works in more developed countries for the time being, because there is a cost attached to it, a little bit higher cost attached to it when you use two lenses instead of one. It's logical, right? But it's an important call and it's an important argument, this reversibility. So I think it's clear for you. Thanks for confirming. Sorry that you just please continue.
No, it's fine. So there are multiple indications. It's not only about going for reversibility, but for example, if the patient has some family members who had already developed, for example, macular diseases, it can be also an argument because it can be expected that probably this patient will also develop some macular disease one day. And for these macular disease patients, like AMD or other pathologies, the trifocal lenses are not an option. And in this case, the trifocality can be removed and the patient will be safe again. And here you can also read about the anatomical prerequisites, because of course, in very small eyes, of course, the AddOn probably is not the best choice, but I think these standard measurements are always done by the doctors, and he can decide whether his patient is a good candidate for the AddOn or not. And we also show some clinical data from Australia. And here you can see that if you compare the results, either the refractive outcomes or the visual outcomes with similar optics, trifocal lens by Medicontur, the Liberty lens, these two setups are identical. So it's okay if you implant a trifocal capsular bag lens or a monofocal capsular bag lens along with a trifocal add-on. It is as good as. So we have no problems. And if you compare the visual function of the patients in different everyday activities, they are also very much similar and they give a really good rating. On this scale, you can see the best rating is 0. The worst one is 5. And here you can see really nice, small ratings for both the trifocal lens and for the dual implantation approach. And on the back, inside of the back cover, you can see some testimonials from doctors who regularly use this approach and who already tried it. So this is also a proven technology. And on the back side, again, you can see some references if the doctor is interested in the details. So this is for the dual. We knew that it's a new concept, but it's very much trending, and it's going on also in Germany, Australia, and it's spreading all around the world in different countries.
And you understand, Joanna and Carmen, of course, that these are different types of surgeons that you give this material to. So obviously, a lot of the refractive centers where there's very small amount of residual refractive errors. So, you know, you have those centers that are so precise these days with the very high efficiency or very high efficacy diagnostics and the very efficient surgery. So those types of centers, if they do a high amount of trifocal lenses or multifocal lenses, you have an opportunity to introduce this planned dual idea because they already have a vast, you know, option for choosing their trifocal lens. There's so many on the market, but there are very few solutions, very few companies. Actually, it's only 2 in the world who offer this idea of 2 lenses with reversible approach. So this is really a differentiation factor for you, for your company, and of course for the surgeon himself also or herself also. So this is very important that you understand this. If you look for something special, if you want to introduce a special idea, this is the material to use. And it's also, any questions regarding this specific dual brochure or material, or was everything clear here as well? Yes, thank you. Okay.
Okay, now one more poll.
One last question. Let's see. Yeah.
That's not the last one, but
I think it's,
one
we
before
can make it the last
one.
one. Yeah.
Yeah. Okay. So again, if you got the message, what does dual implantation mean? Is it a trifocal capsular bag IOL plus a trifocal add-on? Is it a monofocal capsular bag IOL plus a trifocal add-on implanted simultaneously? Or a monofocal capsular bag IOL plus a trifocal add-on implanted sequentially, but in a planned manner? Is it a monofocal capsular bag IOL plus a trifocal upgrade 3 years following the first surgery? Or does this only mean binocular implantation? In this case, I told you 5 options, and there might be multiple options which are correct.
So what do you think? Which one? First, second, third, fourth, fifth? What's your guess? Please write in the chat. Let's leave a little bit of time.
Mm-hmm. I hope you can see the question and the possible answers. Okay, Freddie, what if we, okay, we have
okay. Joanna was writing first, second, and third as a possible option. Let's wait for Carmen. Second, third, and fourth. Mm-hmm. Okay, so let's go through. First, trifocal capsular plus trifocal add-on. So that's important to remember that it's not a good idea to have two diffractive optics in the eye. So that's not an option. You have to choose if the trifocality goes in the capsular bag or if it goes in the sulcus. In the dual technology, by definition, it goes in the sulcus because we want to make it reversible. So the first one is not a good answer. The second one, monofocal capsular bag plus trifocal add-on implanted simultaneously. Absolutely, both of you got this right. So this is a correct answer. Third one, monofocal capsular bag plus trifocal add-on implanted sequentially. So not in one setting, in one operation, but 2 different implantations at 2 different dates. Yes, this is also a possibility. What are the advantages of it? Well, if you do it in 2 different steps, you have the chance to even correct yourself from the previous implantation. So you refract the patient, and if there is a need, you can add some spherical power to this trifocal lens as well, or even toric astigmatism corrections. So you have a chance to even enhance your previous surgery. So this is also a correct answer.
Yes, but the drawback is, if we talk about this sequential implantation, that the double OR costs. So there are also pros and cons. So we do not want to say that which one is better if it's implanted simultaneously or sequentially. It should be always decided by the doctor.
Well, absolutely. So 95% of the times you have a simultaneous implantation because of what that said, because of the cost issue. Obviously, you have to do surgeries, is going to almost double your costs. So there's no doubt about it. But the option exists, and many surgeons will probably opt for this as well. So you know, it has to be explained as well. That's the idea here. Monofocal. Wait, which one is coming now? The
fourth one.
The fourth one, monofocal capsular bag IOL plus a trifocal upgrade 3 years following the first surgery. So this one we would not include in this dual implantation idea. Why? Because the idea here is that you plan always with 2 lenses. It doesn't matter if you do it simultaneously or in 2 steps. But from the start, before cataract surgery, the surgeon already knows I will use 2 lenses to arrive at my desired result with this patient, okay? If this idea comes after years, we will not include this in the dual idea. Then we call it a trifocal upgrade. So that's the segment that we discussed in the previous section of this lecture. And binocular implantation is, of course, a wrong answer. None of you said it. Okay. Any question? Is clear? Okay. Thank you.
Okay, then we will go back to the clinic and go on with the calculator guide.
Sorry, Carmen, 2, 3, I misunderstand the upgrade. If this means remove the previous one and implant a new one. No, important. Thank you for asking, Carmen. It doesn't mean removal of the lens from the capsular bag. The upgrade simply means that you have a pseudophakic eye, which has been before implanted a capsular bag IOL months or years before, and the patient comes in and says, I want to upgrade my vision, enhance my vision. And then the surgeon will discuss with this patient what the options are for distance correction, but also for intermediate and near correction. So this means that from a single lens eye, you create a 2-lens optical system for this patient, which then will perform better than if the patient only had 1 lens. So this is the idea behind this upgrade or enhancement after the surgery. The dual is always before cataract surgery. The surgeon already knows, I want to use 2 lenses. Okay, so this is the difference between the upgrade and the dual idea. Thank you for the question. It's important to clarify. Yes, that we go back a little bit to our hospital here.
Yes. So now that the doctor already knows that he wants to implant an AddOn IOL, it doesn't matter if it's upgrade or improvement or dual or whatever, but he would like to implant an AddOn IOL. Then we made a 2-pager to help him know what the main issues are with calculation. What are the measurements? What are the measurements that he will need? And what are the calculations based on? We will give some tips and tricks. And if you turn the page, you can see the access to our medical affairs specialists, Monica and Boglarka, and also to Freddie. All of them can give the doctor or for you, the distributors, personal support when you need it. If you have an unexperienced client, we can help with the first steps. Or if there is a challenging case, they can do the calculation for the doctor and for you. And here you can also see the link to a calculation request form, which either you or the doctor can fill, and you can send it to us, and our colleagues will contact you in a short time and help you with the proper calculation, and they can also give you advice how to do this. So this is only to help you with the calculations, and the calculator is available on the First Q website, which you probably know already. This is just a quick aid and to show that we have this option that you can get a personal consultation as well.
So let's just go back exactly here, the logic, because I think it's important here. It's been a long discussion. So you remember, we all started by identifying some demand, right? In our advice, this is usually the astigmatic corrections, but it can be any demand. You identify the demand and you want to satisfy this demand for the surgeon. So what do? You, of course, start by the clinical evidence and what Detti was introducing to you very nicely, the science brief and the indications sheet, which explains with a very strongly backed up evidence, the safety, the efficacy, and the different indications of usage. So it all starts there. Then, as we discussed, you start to use this material that we introduced to you, the brochures. You start to use the corresponding material to have a better understanding of the process of using this product. So this is what is next. And then when the patient the surgeon identifies the patient, of course, the application side comes in as well, because then you have to provide support to the surgeon how to use it. So it starts by, of course, you have to choose the right lens, which you need to calculate. The calculator for this lens is on the First Q website. It's an online calculator. And here on this sheet that was introducing to you, you can inform your surgeon, what method it uses, what the process of calculation is. We are supporting you with that. As Deti said, we can do the calculation for you, especially in the first cases. We advise that you send us this request form. So you just fill out the data of the patient, of course, anonymous, and we will calculate this required lens power for your surgeon, for you, okay? So this is very important. And then, of course, you have the right lens, you will order it, and then you have to go in the OR and train the nurses and train the doctor for the application side, which of course starts by the loading, very importantly, and we have a separate training for that. I think that we have even a slide.
Yes, we will, but it will be a practical training, and it's a separate training.
This is absolutely the logic. So this is here not the aim of this training, but we organize it. This is more of a theoretical. We organize the practical trainings as well, where we go under the microscope and show you step by step, how to load the lens. And then we also have the indication, the implantation guide, so to speak. So we collected the KOLs, the best and longest AddOn users, collected their advice and created a material out of that as well. So you can use that also for your patients. Again, this is the application side. And we have the same for the explantation as well, because as very nicely, I think that the explained to you in some of the situations, the reversible aspect is important because you can remove the lens, but if we talk about it, then we have to also show how to remove the lens, right? So this is very, very important as well. And you have all these in a separate application package, but it's part of this logic. It's part of this process that we've introduced here to you. So this all what you see gives a system of supporting your clients with this product. And we hope it is useful to you and gives you a better understanding, just to show it in a logical sequence here, everything that we spoke about today.
If we can go on, I would like to show you this graph once again. These light yellowish assets, scientific marketing assets, are still in progress. They are not ready yet, but will be released very, very soon. And now we will go on with the contents aimed for patients, the trifocal patient brochure and the trifocal patient video. We do believe that it's very much important to help the doctor to reduce this chair time that he will probably have when explaining the patient the concept of the trifocal upgrade or the implantation of any trifocal add-on lenses. So first, let's see a patient brochure. It's very important that it won't be put out in the waiting room. It is the doctor who hands out this document to the patient. And if the patient requires, the doctor can give a short explanation of what the patient can read or see. But of course, we try to write it so that the patient can understand on their own as well. But this brochure does not replace consultation with the doctor, but of course it might help reduce the chair time. I will click on it and you will see that it's an 8-pager. Hopefully will be a huge help for the patients to understand the whole concept about the trifocal upgrade. So this is for patients who already undergone cataract surgery and they still have some problems that they want to solve, but they do not want to use glasses. So this is for the presbyopic patients whose presbyopia wasn't managed when implanting a capsular bag IOL. So we talk about how you can see with a monofocal IOL, because these patients have a monofocal IOL in their eyes. How can you see with monofocal IOL plus the glasses, and how the patient will be able to see with the AddOn trifocal. So in the end, as you can see in this picture here, the patient will have a double lens system in their eyes, one IOL, one monofocal IOL in the capsular bag. But then when she or he comes back to the clinic that she has problems and she wants an upgrade, the doctor will implant a trifocal add-on into the ciliary sulcus on top of the capsular bag lens. So that is the concept. This is an upgrade. And then there are some questions and answers that might be interesting for the patients. So we will try to answer all these questions. And as usual, there are the links for more information both for the patients and the doctor if he needs it.
Comment. You have to make sure that you can use patient communication in your country. Obviously, it's most of the time clear for the surgeon. So this is why what we recommend is, use this material always also for the surgeon. So it's going to be the surgeon handing out this material for his or her patient. Okay, in some countries, I don't know if we have France here represented today. We should have had a guest from France as well. You cannot use direct patient communication. It's just forbidden by the law to use it because it's considered advertising. But in many countries, you can use. So inform yourself about that, and then, of course, discuss with your surgeon if this can be used, because, as Deti also said, it decreases chair time by a lot. The surgeon doesn't have to spend 20 minutes explaining what the second lens means. This concept is very strange for some patients, but can hand out this material, and the patient can inform also him or herself afterwards. So this is the primary idea behind it. And we also have a video, which is an excellent tool for waiting rooms. A lot of refractive surgeons with private hospitals love this as well.
Can we play it, Freddie?
If you can, it would be great.
Please give me a feedback. Oh, sorry. Please give me a feedback if you can hear it.
I cannot hear anything, unfortunately. I don't know about the others.
I can, but probably if we just go through it, and probably they have the link or they already received it. But now just to go through it even without sound.
After this meeting, anyways, you will again receive all the materials. So this is designed so patients in the waiting rooms identify with these problems and identify what is possible to help them. I can hear now.
Yeah, I know. Oh, wait a minute.
The procedure is much similar, yet less intrusive than cataract surgery. The add-on lens can be placed in front of your primary interocular lens, resulting in a dual system. Much like a camera with multiple optics.
This is really useful for the patient to understand the idea behind two lenses.
The add-on lens can correct for near distances or even astigmatism. A clinical study conducted by ophthalmologists at the University of Madrid showed that by the implantation of the trifocal add-on supplementary lens, all examined patients achieved spectacle independence at focus. Over 90% of patients reported being highly satisfied with the surgical outcome in all vision-related issues. Independence from glasses is possible after monofocal IOL implantation. Consult with your doctor if an add-on lens can be an option for you. You have choices when it comes to your vision.
Yes. Social media. We don't want to share this on social media. Again, we have limitations in certain countries, Joanna, to answer your question. So we will not share this necessarily on social media. We plan to work out each country, especially the countries with big potential like yours, about how to use them. So we can discuss separately. If you wish to share it on your social media, it may be an option. It may also be an option to individualize it for you a little bit, maybe put Spectrum logo on it or things like that. So this is a possibility to discuss. This is primarily, I believe, not necessarily for the company advertising or promotion. This is really the best for the private hospital to use. So again, these waiting rooms are always filled with patients, and they have time, and then they have a chance to learn a little bit about their options. So a lot of surgeons love this idea. So this is why we created this. It's very, very useful. We just have to be careful in using them according to the local regulations and rules and work out that side. Okay, so we have to work on this individually. Thanks, Joanna, for the compliment. Yes, it's a great it's a great video, and I believe, especially in the UK, it will also come very useful. So we will speak separately with you and your colleagues how to use it and how to implement it effectively. Okay. I think Samantha is also very interested to use it. Okay. So Datti, I think we have now 1 hour and 40 minutes.
We are almost done.
We can wrap it up now. I think
Yeah, so this is just a quick summary that we already have now, what we have introduced. And you can see that there are some additional materials that are still under construction, but they will be released soon. And as soon as they will be ready, we will let you know. And as Freddie already mentioned, there are some product application materials which will help the doctor. But apart from this, Medicontur is open to make practical sessions under the microscope and help you learn and try these lenses in practice as well. We also have
because the first lecture series, the small group lectures, just like this, or training series, was done for this. So all of your companies, everybody was invited, and most of you have participated on the application training. And now what we build on these applications with the promotion. Obviously, application always comes first because you have to train how to safely use the product in the ORs. This is absolutely important. If any of you have not undergone but wish to undergo, contact us and we will organize another session. Okay, very important.
Yeah, so I think this was it for now. Freddie, would you like to sum up?
Yes, I would like to first of all thank you, Datti, for summarizing everything so effectively. I think this was the first such training. We had slight technical difficulties. We apologize for this, but I believe it was clear to understand. I saw also from your answers that you got the message, that you understood what we wanted to give you today as a knowledge and as a information package. So what comes next is, of course, using it. And we look forward to it in your respective countries. We look forward to hearing from you how you use it, if you find what we explained to you effective today. Okay, so feedback is very, very important. And we will contact you individually with a plan, of course, in your individual countries, an introduction plan of a new promotional material. Now that you understand and know what we have, the next step will come to put it into practice, and this is going to be a separate discussion between you and our company. So once again, Datti, thank you so much for the great presentation.
I would like to add just one more thing regarding the feedback. So it's very important for us to improve. So if you will have, according to your practice and your clients, any important messages or idea for us, how we could improve these materials, which one is useful, which one is not, what else should be included, or what should we develop besides or instead of these materials, then please let us know. You know how to find us. We would like to give the best offer and solutions for both the distributors and the surgeons. So please let us know, and then we will try to do it.
Any questions? Very important. Now is the time. Now is the time to ask anything from us. We have Datti here from Science, who is apologies for the laptop issues. Very useful presentation. Thank you. Thank you very much for the compliment, Joanna.
Yes, and we say sorry. We apologize for these poll issues next time, and that you couldn't speak.
Absolutely, we will share. Sorry, yes, absolutely, we will share, Carmen. Not only the presentation PPT from today, but also again, just as a reminder, all the materials that we talked about, you will again receive from us today. Okay. Again, please come back to us also regarding your colleagues. We count on you to introduce this material to your colleagues. Okay. Of course, it's not effective to have 20 people here because we want to individualize this. But we count on you to use this also in training your own colleagues internally. Okay, so if you need any support for that, you can of course count on us as well. Just spread the message, please.
Yeah, so thanks for joining us this morning.
Thank you very much for all.
Carmen.
Okay,
See you next.
great day, nice afternoon to Asia, and here to the UK. Have a great Friday, and hope to hear from you soon. Thank you.
Okay, bye-bye.
Bye-bye.